The Association of International Educators and Leaders of Colour, AIELOC, launched Self-Care Sundays in 2021, an affinity group dedicated to building sustainable self-care practices for BIPOC international educators. Our meetings focus on networking, sharing experiences, and building sustainable self-care practices for BIPOC international educators.
But the guiding questions for today are: what does BIPOC health look, feel, and sound like to you? How are we as a community healing and growing from the experiences of our ancestors and our parents? What has been the cost of silencing our pain? And that was a question that we had last month. And I thought that that question really resonated also with the experience that we're going to be having today. We'll come back to these questions later. I'm thinking, Dom, before we move forward, I would like us to go maybe into breakout rooms to give people an opportunity to kind of chat and get to know each other more intimately. So if we can do rooms of just pairs, and I'm happy to be the odd one out, and I'll stay in here or I'll pop into a room. So Dom, if you don't mind setting that up, that would be great. And if there's any question on here that's resonating with you, just maybe choose one of them. And when you go into your breakout space, it's an opportunity to share, talk, and explore some of these. If you don't want to enter a breakout room and you'd like to stay in here with me, you're welcome to do that too. But before I start with that, we had our three guiding questions there, and I'm just wondering, and I can't go back for some reason, but I'm just wondering if did anything come up for folks in the breakout room that they would like to share out in this space before we fast forward on to the next section. So there were three guiding questions there. Let me see if I can go back to share them. There we are. If there were any of those, just for the folks who are just joining us, if there are any of these that resonated with you and that you would like to comment on, this is a time to do that. But I've got this little clip here that I wanted to share with you all to kind of get us kicked off. And then afterwards, we can have a bit of discussion around this. And then I'm going to introduce Paula. I think this leads really well into our conversation with her. I don't know if any of you are NPR listeners, but I love NPR, and being outside of the States, it's where I get a lot of my news from. And I feel like often the stories that crop up, if I'm about to do a presentation or something's about to show up, I get this amazing story that I think is really fitting for whatever opportunity I'm about to engage in. And so I came across this a couple of days ago called Seeing the Future in You. And it's a 3-minute audio clip. And I also think it's a great opportunity to listen in and use a different type of tuning in. I know we're used to seeing videos and all of those sorts of things, and I like to stimulate other areas. I'm hoping that everyone can access this. It's auditory. I will share the link in the chat with you as well. If you want to go back and listen to the whole segment, you're welcome to do that. I thought it was really great. There were two distinct parts to it, but this one section really resonated with me for this conversation. So I'm going to stop my sharing just so that I'm able to have you listen into it. And I'm going to also unplug myself. So you're welcome to turn off your cameras if you want, if that's going to help you tune in instead of staring at everybody's faces or things that are going on in the background. You're welcome to do that. But I hope that you'll still be present and listening to what the segment is about, because I think it's a pretty interesting and powerful one. So here we go.
AIDS epidemic started when he was in his 30s. Suddenly, gay men were dealing with the added stigma of HIV and AIDS. It was initially referred to as the gay cancer, and Claude remembers this time with a lot of heartbreak. And just a note, part of this story mentions suicide.
When HIV first hit, we said it was a white boy's disease until our friends started dying. And the way that the hospital staff treated people in those days, the doctors and nurses came in with surgical masks and gloves, and many brothers that were HIV positive just withdrew, and they did not want to go into treatment because of the way the medical profession treated them. You know, I had very folk that were so beaten. One of my younger brothers found out he was HIV positive, and he sat on his patio and blew his brains out. And he was about your age. The stigma is so great.
Claude tested positive for HIV in the late 80s and has worked in the community to prevent HIV infection since his diagnosis. So when he met Richard, who had just been diagnosed, he found someone he could mentor.
How do you think HIV impacts the attitudes of the Black gay community?
I think there's a lot of nobody wants me because I'm damaged good. And that other message, you deserve that. That's your punishment. God is punishing you. We internalize all of that.
Man, you know, I'm openly HIV positive young gay Black man. And if I can openly talk about being positive, it opens doors for so many more conversations. But there was this very fine man that I was trying to talk to, and he was like, you shouldn't tell people your business like that. And I was just like, I love your concern. I get it, but you have to understand that I'm not doing this just for me. I'm doing this for our community. And he couldn't wrap his mind around why I wanted to disclose that type of information.
You know, I applaud you for being that open. But it also saddens me that at 26 that you're infected. Mm-hmm. That means that we didn't do as good a job that we thought we did because you shouldn't, you know?
Yeah. But for me, just having an older Black gay man in my life, it's not only empowering, like I can look forward to being a 68-year-old Black gay man who's living with HIV, right? I appreciate being able to have that role model that you weren't able to have. I can see the future in you. So this brotherhood is something that pushes me every single day to have someone like you in my life.
And I'm glad that we're in each other's lives.
Hey, everyone. I'm about to try to bring you all back. So I'm wondering, after listening to that clip, any thoughts, feelings, wonderings, and I'm going to go back to our guiding questions. If there's anything there that you all feel like you'd like to speak to, I would love to engage folks in conversation around this. If you need a moment to absorb the audio, that's cool too. You can also write in the chat if you like, if there's something there that you'd like to, share. Please feel free. As I said, I just felt that this clip was timely and it really resonated with me for today's topic. And it's one of many to do with Black health.
I think the audio really connects with the second question in terms of how are we as a community healing and growing, like doing things differently. You know, when he talked about the fact that he doesn't shy away from telling people his status, his HIV status, but the guy he was dating was saying, well, why? You don't have to tell people that. That's your private business. To me, it reminds me of becoming a counselor and working in inner city schools in DC and in Boston, and having kids come into the counselor's office because teachers sent them and saying, I don't want to talk to you, miss, because my mother said, don't tell that counselor our business. Keep our private business to ourselves, you know. So trying to help students and families understand that the counselor's office is a safe space, that you can share things that you're struggling with. And I'm not there to shame you or judge you, but my role is to help you manage those things. But, you know, so that's what it connected. It brought me back to that, but it connects with that conversation in terms of how can we do things differently.
I would like to chime in as well. Just listening to that clip, it took me back to like childhood and some memories. And so for me, I'm looking at the first question: what does BIPOC health look, feel, and sound like to you? And for me, it looks like community. It looks like supporting each other. Like listening to that clip, I was reminded of, I guess maybe I was like maybe 6 or 7, And like the family that lived next door to me, I guess like the relationship, like my mom was like dating like a member of this family. And so since we lived right next door, we would always be like in and out of the house as kids. And they took in someone who was living with AIDS. And they just kind of brought back that memory to me of like that community, you know, just even if your own maybe family doesn't take you in, but there was always someone willing to help to be that support system across disability.
It made me really think about, I'm not sure if that was in part of this clip or another section of those two men sharing, but the older man talking about how a lot of our men who at that time, you know, back in the 80s and 90s were being diagnosed, they like were refusing to go to the hospital and to the doctors because of historically the way we were treated, and also because they saw it as, oh no, that's that white man's disease, that's not our thing. And it really resonates with me, like in the most recent pandemic that we were having, and how a lot of particularly older Black people and brown people, because I heard stories about them as well, not being comfortable going to seek professional help and going to the doctors, because historically we haven't been allowed access, and people don't identify it as something that they're going to be able to get help with. Like there's a number of reasons, and I just thought, wow, we're still in that same place today. But the silver lining was the younger Black man saying, I'm open about, you know, this disease. And so it's like, yeah, we're shifting that stigma slowly, and it makes me have hope for the future of Black health and people in our communities being open to seeking support and help.
And then listening, it almost reminded me of, you know, going back to what you were saying, Twana, around current days of monkeypox. So when monkeypox, I'm situated in the US, and when monkeypox came out, right within the first part, it was quote unquote a gay disease. And then it's sort of like people quickly sort of said, weren't we here before? Didn't this happen, you know, in our previous lifetime? And in terms of like treatment, and it's interesting to see how sort of monkeypox media-wise that spread widely, you know, and I remember seeing news, you know, UK and other parts of Europe and parts of the world. But then all of a sudden it dissipated. You saw little to no information, you know, on monkeypox. And I think part of that, you know, that piece on just health and being able to visualize, one thing that stood out to me from that quote was, or from the dialogue, was the piece on the young man saying, I can see myself. So it's also him being engaged with the community, but seeing someone who was older, who was almost like a mentor, and being able to visualize himself living, you know, his life fully, because he was, you know, saw someone who was older. And I feel like health-wise, I think about things like messages and what you were saying. I mean, remember, like even my mom, her generation, my older aunts and uncles talking about Tuskegee and talking about some of the medical malpractice and things that they heard of or knew about. As one of the reasons why they don't trust things around vaccinations and doctors. But then our generation, at least family-wise, and then people who I know, just sort of saying like, hey, and checking in on things around like physicals, and just sort of how are we engaging around when it comes to things like mental health. So thinking, you know, past and listening to them, and present, obviously messages, but also how are we going to ensure that we're doing our checkups, but also being very intentional about who does our checkups. You know, I knew for me, when it came to therapy, I'm very intentional around, you know, I had white therapists, and I just felt like I wasn't myself, but I'm very intentional around making sure that I'm picking therapists who identify who I can identify with. So I've had Black gay therapists, same thing with doctors, making sure that I'm picking doctors who I feel comfortable with.
I sort of focused on the cost of silencing our pain, and just how I feel with Black and brown folk, in just especially sort of the older generation. I think, Tawana, you sort of mentioned older men, and how hard it is for us to speak up, just because of the history of the treatments of in the healthcare and mental health as well, for expectations for like Black and brown folk, and whether they should be in that space or not. And I know I've had various forms of counselling over the years, and I always, wondered whether it's okay for me to be in that space. And as an older person as well, you sort of see, well, should I be doing that? Should I, am I allowed to be there? I think that was probably what a lot of it's sort of been about with me, and just, I think thinking about the space I'm in now, because I'm an international school teacher, the cost of just silencing that, and the experiences that maybe I've had and other folk have had as well, is it will perpetuate what's happening. So the spaces that are opening up now more and more really, really help. Because you can feel in a safe space, you can feel comfortable to talk more, hopefully, and it allows us to sort of get things out, and that's how I've sort of feel, and especially with in a way what they were sort of mentioning in the clip there.
Thank you. Hi, everyone. I was also thinking about this last question, and about the cost of silencing pain. And I'm just going to speak from a purely Black American perspective here, as someone who grew up in the South, and the role that the Black church has had in silencing in some ways, just personally, and what I've noticed for some others. Growing up in a semi-religious family, not as hyper-religious as some others, but when some of my family members would express that they were struggling with their mental health, or struggling with some pain or anguish, the response would sometimes be, just pray about it, just pray on it, and that was that was supposed to be the cure. And there were some, I would hear sometimes oh, therapy is for white people, or we don't need that, we just need the Lord, we just need Jesus. And talk to pastor about it. And pastor is not a psychiatrist or a psychologist or a therapist. And this, I think that it was limiting in some ways, and continues to be for some, and also invalidates pain sometimes, when it's just pray about what you're going through, everything's going to be okay. I think that there is a place for prayer, if that's what you believe in, but that does not that does not always help with mental health crises that some of us face and endure. So I just wanted to put that out there.
I am so in agreement with you, Constance. When you were saying that, I just finished telling someone about my grandmother passing away because their family was very much steeped in the church. This woman is having, I don't know what stage, cancer, and they're all praying over her and stuff. And by the time they finally got their act together, to realize, oh, all of this prayer and this person we brought into the house to pray over her and do whatever kind of shoo that they do, it was too late. And she ended up passing away from a cancer that is curable. And so for me, it's just like, how many people in our community have died because of that, you know, the whole let's pray about it and put it in God's hands. And it's like, yeah, that's one thing. But another thing is we need to put it in the medical professionals' hands so that we can eliminate unnecessary deaths. Yasmin, you have your hand up, so I'll stop talking.
Thank you. No, I just wanted to say that what Constance was sharing really resonated. And, you know, Dom and Kevin also brought it up, is this whole idea of getting help. I think, obviously, you know, whatever was modeled for us when you know, as we were growing up, it's very much, as an Iranian, I have to say, I've known for several years that, you know, someone like my father or my parents, you know, they not only did they live in Iran in their teenage years, but they moved out of there around the age of 18. And so coming into a new place where we know now there's so many inequities, and so they're facing those as they're like end of teens, going into their 20s, having kids, having the kids be baptized so that they're accepted as Catholics, et cetera, just a whole load of things. And in the end, I remember having this conversation with my father, I think it's like 8 years back, about who helped you, you know, Dad, deal with all these emotions? Like, did you ever consider going to therapy, et cetera? And it really is for my parents and my friends' parents, I can vouch for, it's such a taboo. And so the lack of then getting help has a harmful effect on not just themselves, but on their whole community. And now with what's happening in Iran, you can see that people are just like paralyzed through the visible trauma now that has become more accepted. And so it's what the voice, the audio clip awakened for me in a way is that we spent so long with like stigmatization and taboos that so many people suffered in silence and still are. So yeah, I tried to be coherent there, but that's what came up for me.
I wanted to introduce Paula and give her an opportunity to discuss with us. But before I have her speak, I just wanted to give her a brief intro through her bio. Paula Wheeler is a Detroit native with a passion for advancing health equity for the global Black diaspora. I had the pleasure of seeing Paula a few months ago here in South Africa, where her and I both work. She had a session after work one day with some Black professionals. And I remember thinking, oh, I don't know if I want to go. I'm tired. I'm not really a Black professional in health. But I thought, wow, this is a great opportunity to network. And it's a space that I am really curious and interested in, particularly since we are, you know, I'm co-facilitating this group with other international educators. It's an area for me that I'm wanting to find out more. So I went along to listen to what she had to say, and I was so glad that I did. Paula's from Michigan, and she has a master's in public health from Emory University's Robbins School of Public Health. She is the co-founder of Black Health, a nonprofit that aims to disrupt the pathways between racism and poor health outcomes. Black Health utilizes some of the core tenets of critical race theory and anti-racism practices in trainings, research, events, and media to empower healthcare organizations and Black communities to resist systematic racism. Paula also currently manages a national HIV initiative in South Africa, and she has experience in facilitation and curriculum development for healthcare programs in Asia and Africa. So Paula, welcome to our group. Thank you so much for being here to share space with us today. I'm so happy that you could join us.
Okay, well, thanks everyone for having me. I'm really happy to be here and be able to tell you all more about my organization. I love doing this. So yeah, so just my organization, it's a 501c3 tax exempt nonprofit. called Black Health. And here on this slide is our vision and our mission. So we envision a world where racism and other intersecting forms of oppression do not determine a person's ability to achieve optimal health. And then what we do is we engage the public and health professionals on the impact of racism on health, and then equip them to do something about it. So I'll talk a bit more about the different programs and services that we offer. Just to give you some background about how we got started. Actually, so myself and the three others in this picture here, we are all close friends from Emory School of Public Health. So just after we graduated, we decided to start this organization because we felt like when we were in school, we didn't learn, like in our master's program, we learned a lot about health disparities or just that they existed. So, you know, when you would look at any chart or graph of like displaying health outcomes for different populations, you know, it's always worse. What you'd see is worse, higher mortality rates in Black people. So we kind of learned those statistics, but we didn't feel like we were learning a lot about like, what are we supposed to do about that problem, racialized health disparities, closing that gap between Black folks and white folks around health. So that's kind of what we created the organization to address, is trying to figure out what we should be doing. How do we spread that knowledge to healthcare workers and to people in our communities? So I'll talk a bit more, like I said, about what we do. So this is our team. It's myself, Marcilla, Khadijah, and Matthew. It's the four of us who co-founded the organization. So what we do, so one of the things that we do is we hold community health events. So we intentionally design and implement events that break down barriers that Black people often experience in accessing health promoting information and services and resources. We have two events, kind of like our main event series that we host. It's called Ask a Doctor and Black Health Conversations. So our Ask a Doctor event, what we'll do is we will bring, we'll usually host it around like a particular disease or something like that. Sometimes it's not always a particular disease, but it's usually around a particular health condition. And then we'll bring in doctors and like other specialists who work in that particular condition and can speak very knowledgeably about it. And also provide some resources. And we'll bring them together with just different folks in the community. So we always, like when we do these kind of events, they're always free. We usually try to, do our due diligence and having them in a location that's easy for people who would normally have a hard time accessing health services. So we'll do them at, in Atlanta, we'll do them at libraries that are often on like bus routes, things like that. We'll do things like we provide like a Lyft code or an Uber code that people can use to get there and not have to come out of pocket just to get there. We try to offer free food and drinks at our events as well, just to kind of like draw people in. But, the point of what we try to do is to have as little barriers to entry as possible for people in our community to be able to attend these events. And so with the Ask a Doctor, it's kind of like this bi-directional knowledge sharing. So obviously the doctors, the specialists, experts, they share all of their like scientific knowledge and other things that, they know about the condition. But then what the community really brings to it is that they kind of can share their concerns, their questions, any other pressing issues that they have. And I think it's been very helpful for both community members and for our medical providers to have that open conversation. And so, taking these conversations and these discussions outside of the clinic or the healthcare center and putting them just where the people are. And with Black Health Conversations, what we do is kind of like do like a brainstorming solution-based session just with like more like community members or other like interested folks around a particular topic. So we'll often do like just like some activities, some guided, like facilitated discussion. Then we might have like also open discussion, breakout groups, things like that, around a health related topic, and talking about the impact of racism, what it's like to deal with this as a Black person, and then kind of like what we can do moving forward. So we do kind of try to be like solution oriented in our Black health conversations sessions, but they often just become a space for people to vent about different things, learn different things as well. Yeah, and so we do those events in person and we do them virtually. We also have been lately like hosting some pretty like more large scale events. I'll speak a little bit more about it later, but we have a partnership right now with Cottonelle, where we are distributing at-home colon cancer screening kits. So we've been doing these like kind of large events. We've done them in Atlanta so far and LA, where we're experimenting with this idea of like a health festival. So you bring in all the elements that people like of a festival: music, food, drinks, just having fun together, vendors, things like that. But what we'll also have are a lot of different health services. So we'll have on-site HIV testing. The event we did in LA, so we had HIV testing, COVID vaccines, monkeypox vaccines. There was someone there, a group there that was providing take home like fentanyl test strips and Narcan. There were some other, I think there was an acupuncturist doing service. Oh, and then we also had lots of therapists. So we had like 3 different Black therapists, one who was a Black man, and we were directing people to go and like talk to them, just like ask them questions about therapy, like, what does therapy look like? What do I have to do? How do I get connected to therapy? Yeah, and just like getting, just really trying to get people like more sensitized around these different things. So like, if you have questions, if you're curious about what to do with therapy, like there's someone here who is Black, and you can talk to them and you can just ask them your questions and just feel a little bit more comfortable as well. If you are curious about monkeypox or the vaccine, the COVID vaccine, there's someone here that you can directly ask a question to, and just like really building community in the way that, Black people like how we like to do it. And building trust as well, like that's a big issue, right? Like, and it kind of ties back to that clip that we heard from the NPR podcast. Just like feeling mistreated by medical professionals, it really breaks down the trust. The racism that we experience in the healthcare system causes us often to not trust the healthcare system. So we're kind of, doing our best to work on that. And so that's why we just have these more laid back events, more fun events, where people aren't forced, you don't have to get a COVID vaccine. You don't have to do anything. You don't have to get a test. But if you want to, it's there. And if you want to talk to someone about your different options, you can do that as well. And as well, so we do health programs and initiatives. So we build partnerships with different corporations, organizations, and brands to provide resources and services to Black communities. So our biggest one right now is what I was talking about, this partnership we have with the tissue company Cottonelle, and it's called Good Down There, the campaign. So the Good Down There campaign is all about like down there health. So we're being a bit like funny and like cheeky, because it's a tissue company. And so we are like thinking about kind of going in maybe different directions with it, but currently, so we're in year 2 of that campaign, but currently it's been based on colorectal cancer. And if you all remember, that's what our Black Panther, Chadwick Boseman, that's what he died of at a very young age. And so that's what we've been spreading awareness about, is that Black folks often get diagnosed at much later stages of colon cancer. And so they're more likely to die of it. And it's something that can be preventable, or just like the outcomes of colon cancer, like there's a lot that can be done if it's caught early. So the fact that we often don't catch it in time, it's not a good thing. It's really bad. And it just speaks to how there's so many barriers for us in the healthcare system. And so we don't even go, we don't get tested. We're not even, thinking about that, like to go get tested for colon cancer. And then the fact that I think the screening age is low, is higher than what it needs to be actually for Black people. It's kind of like an average general screening age, but that doesn't work as well for Black folks. I think it's screening age was recommended at like 45 or 50. But like Chadwick was like 40, early 40s when he passed. There was another Black celebrity who, a lot of Black people, like we've been finding like through this campaign, were they passed from it well before the recommended screening age. And so, yeah, so just we have a whole different kind of relationship and situation going on with colon cancer that we need to spread awareness about, that people need to know, and they need the resources. So in that campaign, what we do is we send out at-home colon cancer screening kits all over the United States. So we are targeting predominantly Black cities or cities with significant Black populations. So we work with partner organizations in Detroit, Houston, Oakland, LA, Atlanta, of course, Philly, Chicago, quite a few other cities as well. And we're looking to continue to expand. So looking to expand to cities like New York and other cities in the South, especially just getting partners that we can then send kits to, who then can distribute them to their communities and populations that they serve. So the kit actually comes with a Cottonelle roll of toilet paper, Cottonelle wipes, and of course the at-home colon cancer screening kit, and also some Black Health branded merch too. And then as well with that campaign, one of the things we have is a $300,000 fund that sits with the Colorectal Cancer Alliance. So, and this was something that Black Health pushed when we got into this conversations with Cottonelle about how we're going to build this program. We said, we can't just send people at-home screening kits and then, recommend that they then go get tested, get a colonoscopy, which is the next step. If their at-home test comes back positive, that they then need to go get a colonoscopy. So we can't just tell people like, go get a colonoscopy and good luck, because we know that the other thing that Black folks really, disproportionately struggle with is access to health insurance. So if we don't have health insurance, then it's not likely that people are just going to pick up and go get a colonoscopy. We cannot afford it, can't afford to pay that out of pocket. And so we have to provide people with the financial resources as well to do these recommended healthcare actions, that we are asking them to do. So that fund sits with the Colorectal Cancer Alliance, and it's been used not only to pay for people to get colonoscopies, but also it's been paying for some people's cancer treatment as well. So we're just really proud of that work that we've been able to do and helping people. And we also just do like a whole campaign around it, like a lot of education. We do social media posts and partnerships with influencers and things like that to really spread awareness about the impact of colon cancer in Black communities. So we've done similar partnerships where we sent out like at-home HIV test kits. So we did that partnership with Shea Moisture. We sent out HIV test kits, co-branded like Black Health Shea Moisture kind of campaign. So we really have gotten into this space where we're working with corporations as well to like get resources, like for them to use their funds and their influence to get health resources to Black communities. So we're very excited to do that, and just looking for more partnerships like that where we can really get products and resources in people's hands. And so that's been a journey of figuring out how to really do that effectively, and something we're still learning. Definitely we're still learning on that, but it's been a really good experience, just seeing like the impact that you can have. And as well, so one of the other things that we offer are our anti-racism workshops. So these workshops are really targeted towards emerging health professionals and current health professionals in universities, hospitals, other institutions, to really get them thinking about what racism is, first of all. Like, that's one, like, you know, we all kind of sometimes work with different definitions of racism, but we really are trying to push a definition of racism that's about structural racism and racist policies, practices, and norms that persist in our societies that then lead to health disparities. And so threading that needle for folks about how we're defining racism, and then how racism causes poor health outcomes for racialized groups. And for us, you know, in particular, we're talking about Black people. And then we turn to then looking at critical race theory as kind of a toolbox for dismantling that. So there's already been a lot of scholarship around critical race theory, the application of critical race theory to public health. And so we translate that scholarship for people, you know, in a more digestible format, and just kind of teach them about the tenets of critical race theory and just other anti-racist principles that help them in their health research and their practice. So things like one of the core tenets we teach on is called centering at the margins. And if you remember earlier, in our vision is that we envision a world where racism and other intersecting oppressions do not determine a person's ability to have optimal health. And so we're really intentional about talking about intersectionality and how, like, racism, you know, is foundational to the issues that we experience, but there are other isms, right? Other phobias that are affecting Black people, and they interlock. So as a Black woman, I experience racism and sexism, and the way that the racism I experience is sexualized, is gendered. And so we talk a lot about that. And so in the tenet, centering at the margins, it's about, you know, when you're working with a population, like if you want to have a healthcare program that targets Black people, think about the different types of Black people who are the most marginalized. So how will your program actually affect transgender Black people? How will your program help the poorest Black people who live in poverty, not only those who are middle class or things like that. So the people who have the biggest barriers to accessing resources, how are they going to get benefited and helped by your program? And so I think a lot of what we see, you know, people often overlook that. They just think, you know, they look at Blackness as a monolith. And so they don't think critically in their program planning and implementation about how they're really going to target specific, even, you know, I guess you could say, like, even more oppressed facets of Blackness, you know. So that's just like one thing that we talk about. But yeah, we've done these courses at different institutions. We provide them virtually. We can do it in person. They're very interactive. So we don't just stand in front of the room and just lecture. Like we ask people to bring their experiences to the table to help inform the learning that's done. We also do some research and just consulting and just different things. I mean, people can like reach out to us for like almost anything, you know, and we'll you know, if it is helping Black folks improve health, we are usually like down for it, where we'll be at the table. So we've been lately providing a lot of guidance on research studies on like bringing in culturally humble, intersectional, and safe approaches into their research. So like we think about anti-racist principles like in the entire design. So like I said, what we teach about how to incorporate anti-racism in your research. So now we also practice that. And different institutions will kind of tap on us to bring that perspective to the study what they're doing. So that's been a really interesting kind of role that Black health has been playing as well. And then we do a lot of health education just on social media. So we are everywhere. We've got TikTok, we've got Instagram as our biggest platform, but we're also, you know, on Facebook, on Twitter, we have a podcast. So we create a lot of media as well within Black health, media around, just awareness around just different health issues and topics. So I can share this presentation with Tuana, and it can be distributed as well, because you see it has these links here to different videos and things that we've done. Yeah, so I really enjoy that aspect of like creating different media and talking about these subjects. And one of the things that, is really important for us is that, we're all millennials that started this organization, and we're just like, look, like we saw what happened with COVID, like the way that health is communicated, health awareness is communicated does not work. Like it's not working. So we not working for our communities, right? Like we saw all of the misinformation and just, things like that that were going around at the height of the pandemic. And we just try to talk to people in a way that's relatable. So we are not like stuffy. We will curse. We will talk about our, like we'll talk just like you're talking to people that but we also, for us, we know because we are trained health professionals that we stick to the science and we stick to the facts. So that is very important that we are being accurate, but the way that we present that accurate information is hopefully sounds like, relatable in the way that a lot of this like fake news and things like that is also being presented to people, getting people on Twitter and things like that. So I do feel that like people come to us, like they trust us as a source around a lot of these topics. And I think it's because of the way that we engage with our community in a way that we are a part of the community. We are not lecturing you, talking down on you. And I just feel like that approach has really been working for us and has created a lot of just, good sentiment around our organization. And I want to definitely keep that going. Yeah, what time is it? So I could pause here. Yeah, I'll pause here. I did have some more slides because I was going to give you all like a little bit of a taste of like what we teach on. Like I said, like here it says how racism causes health disparities, but I can pause. And like I said, I can also just I'll share these slides as well. So I just wanted to like give you all an opportunity to respond, ask questions, things like that. Cool. All right. So yeah, so I wanted to talk a little bit about like, just our platform, like, how it is that we are connecting racism to health disparities. So health disparities, they are the differences in the health status of different groups of people. Some groups have higher rates of various diseases and chronic illnesses and more deaths and poorer health outcomes compared to other groups. So when we talk about racialized health disparities, we are describing the increased presence and severity, certain diseases, poor health outcomes, and greater difficulty in obtaining healthcare services for disadvantaged races and ethnicities. And the social determinants of health are the conditions in which people are born, grow, work, live, and age. They are sometimes considered like the non-medical factors that influence health. And so they are things like education access and quality. So the better, more quality education you have, the more likely you are to have, better health outcomes. Healthcare access and quality. So yes, your ability to have health insurance, and then obviously the quality of the healthcare systems that you interact with will then affect your health outcomes. Neighborhood and built environments, so safe neighborhoods, clean neighborhoods, neighborhoods with green spaces, versus neighborhoods that are polluted, high in crime and violence. Obviously, those things will set people on different paths towards certain health outcomes. Social and community context, so strong social bonds, community bonds, stigma, things like that that can exist in your social life affect health outcomes. And then, of course, economic stability. So the type of jobs that people have. And then the, we definitely, COVID is a great example. The people who were heaviest hit were those essential workers, people who work a lot with the public. And you saw Black people and other people of color being disproportionately represented in those types of jobs. So that kind of falls under like the economic stability, job opportunities aspect of a social determinant of health. Oh, and I was going to say as well, it's because of racism's impact on the social determinants of health. You know, we have different, because of racist policies and practices, like Black people are more likely or less likely to have like good schools and quality education. And like I said, like education then affects, is a factor in health outcomes. So it's racism's kind of like lasting impact on these social determinants of health that then make racialized health disparities persist. This is a conceptual model that links racism to health outcomes. So you can see on the left side, the kind of like seed is the racial discrimination. And that leads to lack of resources. So denial of goods, resources, or services to certain people. Racism also causes just physical, like psychological stress. And then it also can lead to things like just violence, right? So then that's kind of like these intermediary factors. And then those things lead to when you've had things like, you know, being denied goods and resources, that'll show up in like the neighborhood conditions. So poor living conditions, decreased quality of care. And then with psychological stress, then you get, you know, mental health issues, negative coping behaviors. You also get a physiological stress response. So higher cortisol levels, increased heart rate, things like that. And then all of those things then can lead all the way here, you see on the right, negative mental health outcomes, anxiety, depression, substance use or misuse, physical health outcomes. So heart disease, you see it in maternal and infant rates, health outcomes, increased blood pressure, physical injury as well, violence, gun violence, you know. And so just this is just kind of like a model, like I said, like that can kind of just like help you walk through exactly what we mean. Like racism actually causes poor health outcomes. So these are kind of like the steps. Yeah, and then I also, yeah, so just kind of tying back to what we were talking about with the NPR podcast, around HIV, and I just thought that was such a salient like snippet of that podcast. So these, what I'm going to present now, are some social media posts that that I created for our Instagram, that just got a lot of engagement, a lot of conversation around them when we posted them. And so this is like what we like to do is explain, you know, explain, draw, like thread that needle, like I said, like what are we saying? Like racism causes, you know, affects HIV outcomes. So I just made some posts that were explaining that. And so, yeah, talking about 3 different kind of like racist policies. So, and this is from a US perspective, but I think, you know, we can find parallels to these in a lot of other countries and different cultures and contexts. So with redlining, so redlining was a discriminatory practice which denied access to credit for borrowers in neighborhoods with high percentages of people of color. So the FHA entrenched racial segregation by stipulating that the presence of incompatible racial and social groups in neighborhoods should be considered negatively in the mortgage lending process. So basically, redlining imposed barriers to the flow of capital in many low income, in particular, Black and POC communities. And it created the foundation for long-term disinvestment and the concentration of poverty in Black neighborhoods that can be seen today. So redlining created ghettos, right? I'm from Detroit. Detroit is a highly redlined place, a very racially segregated place. So this is something that, even though the practice itself like legally has ended, you still see like how it continues. It actually continues in its own way. There's still lots of racism in like neighborhood development and the flow of capital that goes into certain neighborhoods versus others. But I mean, even in my own life, you know, like my life has been affected by redlining as, you know, a Black person living in Detroit. And so how this connects to HIV is that what redlining does, like I said, it creates these pockets of concentrated poverty, like I said, what we call ghettos. And so poverty is like one of the biggest risk factors for HIV infection among straight people living in urban areas. So Black people are disproportionately affected by HIV because they are more likely to be poor and living in impoverished neighborhoods due to racist policies like redlining. And then also living in a poor and impoverished neighborhood, it exacerbates the challenges of living with HIV. If you do have HIV, so experiencing unstable housing, food insecurity, a lack of consistent access to quality healthcare, all of these things are caused by that disinvestment in Black neighborhoods that redlining created. That makes it very difficult to actually manage HIV and achieve viral load suppression. So if you're not managing your HIV, you may be spreading HIV. So you can see how it's quite cyclical. And then, yeah, like how a policy like redlining then has implications for a lot of the different social determinants of health: education, healthcare access, food, communities, neighborhoods, things like that. So that's one example. That was one racist policy, was redlining. Then the other one is the coverage gap. So the coverage gap refers to the lack of access to health insurance for adults with incomes too high to qualify for Medicaid, but still below the minimum income eligibility for tax credits through the ACA. So basically, people who fall in the coverage gap can't afford health insurance offered through the ACA, and they can't get Medicaid either. And so, as I'm sure a lot of you know, like most states did expand Medicaid to provide health insurance coverage to those adults who would otherwise fall in the coverage gap. But there were 12 states that opted not to expand Medicaid, and the majority of those states are in the US South. And you see opposition to Medicaid expansion, it's highest in those conservative states where racism is abundant. And so not only is it like in these states in the South where there's a lot of racism, but most Black people actually live in the South, just because of our history through slavery. So when things fail in the US South, when services fail, it's Black people who are disproportionately impacted by those failures of Southern state governments, and in this case, like to implement Medicaid expansion and provide access to healthcare for its poorest citizens. And we see on the flip side, in states where Medicaid was expanded, racial disparities in health insurance coverage and access to healthcare are closing. So just giving people access to healthcare does a lot. And in particular, with HIV and AIDS, having healthcare is critical to gaining access to HIV-related care due to how expensive it is to manage the disease. So people with health insurance more likely to get tested for HIV. They're more likely to begin and remain on treatment if they have HIV. Also, 3 out of 4 of all people living with HIV in the South are Black. So sorry, I know that might be like somewhat of a confusing statistic. So out of the people in the South who have HIV, 75% of them, 3 out of 4 of them are Black. So the most people who have HIV in the South are Black. So we bear a disproportionate burden of HIV in the South. And so we can see how the persistence of the coverage gap in the South in particular is a major barrier for Black Southerners in accessing the healthcare that they need in the face of the HIV epidemic. So it was redlining, and it's also the coverage gap and failure to expand Medicaid. And then the third one that we talked about was mass incarceration. So mass incarceration, it's a result of several criminal justice policies that have a disproportionate impact on Black Americans. But those things include, not limited to though, harsh sentencing laws for drug and sex offenses, policing practices that target specific areas or people, things like stop and frisk, and just the targeting of Black people by the police for certain crimes. And then these habitual offender laws that are on the books in some states, like the 3 strikes law, which says if you have 3 felonies, I think it's like you automatically get life after your 3rd felony, after you're convicted of your 3rd felony. So these kind of like mandatory sentencing minimums have a disproportionate negative impact on Black people in the criminal justice system. So how does this relate to HIV? So yeah, racial biases held by police, prosecutors, judges, and just the structural disadvantage in Black communities related to poverty, housing, employment, again, those social determinants of health, they lead to Black people being disproportionately targeted as criminals and sentenced to prison. So Black people are in the United States seen as like being, you know, they're shown in the media and just general sentiment is like they're seen as problematic citizens who need controlling. So that's where the over policing of Black communities comes in. And so you see huge amounts, disproportionate amounts of Black people going to prison. And then you have a problem, you have a healthcare problem in prison. So HIV prevalence among incarcerated people is 3 times higher than among the US general population. And incarceration itself is a barrier to HIV prevention and treatment due to the necessary health services being severely limited or just completely unavailable because of the lack of resources in prisons. And then also prison health services often have too few or poorly trained staff. Staff often have negative attitudes, stigma towards people living with HIV. And so for people living with HIV who receive care and treatments like in the community, being locked up in prison is a very disruptive event for their treatment plans and then adhering to their medication. And then on the other end, so this is kind of like, you know, something that's very important for people to understand is like when someone goes to prison, like they don't stay there. Most people aren't staying in prison forever. Most people get out. And so most people kind of go in and a lot of, not, I won't say necessarily most, but a lot of people go in and out, right? Like it becomes a cycle in your life. And so people who are in prison, incarcerated people are also in our communities, you know, like this, it's a cycle. And so what's happening to incarcerated people then spreads to people who are not incarcerated, that are also part of their community. And so in the weeks following a person's release from prison, it's a very vulnerable period and high risk HIV related behaviors may increase. And then access to healthcare is very low for most former inmates. They lack health insurance because they lose their health insurance when they're incarcerated. And they also just lose their ties to a regular source of care in the community. So you can see how it's a very, we say racism is a wicked problem because it's very complex. There are a lot of different actors. There's a lot of different factors to it. But I hope that just kind of like going through this slide set that we put on Instagram as well, kind of helps like give like concrete examples of what we mean when we say the racism that's prevalent in the systems then causes us to have poor health outcomes. And HIV is just one example. I mean, you can kind of do this same exercise with a lot of, you know, we could definitely do this with COVID. And then, you know, just different things, maternal health as well. Yeah, so we see this across a lot of different health conditions. And that's all for me. So thank you so much for listening. And I definitely welcome any questions or comments, or, you know, if folks want to get in contact with me later, my information is in the slide deck of how I can be reached. And we're on Instagram, social media, we're on the internet everywhere, BLKHLTH. So it's blackhealth.com. And that's our tag as well on all social media.
Thank you for all of this and for having me in the community. I am starting a company called Be Beyond Bias, which kind of works on mental health. And so I'll share those contacts later. But just to be here with all of you, you've like, just hearing all of it's just been wonderful. And thank you for having me.
Yeah, I just want to say thank you. Second or third time here in this group. So it's always just fun to be here, share. So thanks so much for creating this space again.
Thank you, Paula. That was amazing. I think we know some things, but to see you lay it out in that way, it's kind of connects some dots for me that I had not, you know, thought about in a while, or maybe even ever thought about. So I think it's a great resource. And I'm glad that we decided to record it so that more people can get the information and follow you on social media. And for those people who obviously, are in the US, they can participate in the Good Down There campaign, because I think that that's an amazing resource as well. So thank you so much.
Thank you. Yeah, and if you all have family members in the US that you can order a kit for them. You can get them, or send the link to them. I'm gonna put the link in the chat. But yeah, I mean, it's no pressure. It's a thing you can just send, and they don't have to use it if they don't want. But yeah, it's a good resource to have. So I put the link in the chat of how to actually order one.
Paula, I'm just curious to hear your thoughts about how, since the last time I saw you, and I heard you speaking about the festival, I'm calling it the festival, that you were thinking about putting on around Black health. And I remember that came up in conversation too when you were presenting to the Black healthcare professionals. So I'm just wondering, has there been any sort of uptake or more movement towards, I don't want to say the word infiltrating, but movement in Black communities around health here? Because I really struggle with seeing the way that looks here in South Africa. And one of the reasons for me coming to your discussion that night was because I want to support my AISJ, my school community, and getting more involved in that. And I know that we have lots of parents who work for USAID and other organizations here in South Africa, and as well as other parts of Africa. And I just really wanted, I really want to expose my community more here, because I feel like the international community of educators all over the place, not just here in South Africa, could really support that work a bit more. And I'm just wondering how we could do that.
Yeah, so we had another event after that. It was like a panel discussion. It was targeted towards like young Black creatives, but talking to them about health and connecting them to some resources. So we had someone from the South Africa Depression and Anxiety Group. Oh, sorry. And then we had like different folks who speak to health in South Africa. So the attendance for that event actually really blew my mind. I mean, hundreds of people signed up to attend. A lot of people came on the day. So it was very well attended, and I just can see the passion for it building and the interest as well. So we are planning the festival type event for Johannesburg, planning that for February of 2023. So I will definitely keep you updated, Tawana, on how that's looking. But we're looking at Constitution Hill as the venue. And then, just being able to do exactly what I described, like a free event. People can come and get, they can get food, drinks, but then there's also going to be lots of testing, HIV testing on site, all types of things going on related to health right there on site for folks.
Thank you. And the other component of that I just remembered is, I think a little bit after I came to your discussion, we had a free healthcare screening for our staff, and particularly for our local staff. And I don't know if anyone else on this call who are working in international schools see this, but in our school, I remember thinking, wow, what a great opportunity our school's providing. But to get the local Black folks to go was so difficult. I was so surprised. I'm like, it's free. Go get your, see if your blood pressure is okay, or your, your cholesterol and all these things. But the resistance there, and just the lack of education and the lack of understanding why those things might be important to do was really interesting. So I thought, we as a school community, I feel like there's some work that we could do as a school community to help that.
Yeah. And that's why we always try to have a hook, we have something else that brings people in. That's why we've got the, hey, if you come, you get some free food. And if you come, you get this. We've got music and things like that. So, because yeah, it's hard. It's hard to like get into those communities of different, get past those barriers of just like mistrust and disinterest and things like that. That's kind of been ingrained sometimes for a long time. So we get people in other ways, and then we sneak up on them with the health part. Yeah.
I have a question. Hi, everybody. Please call me Sunny in this space.
Hi,
Can
Sunny.
you hear me? Hi, everybody. I was just thinking when you said that about my ex husband. He's from Sierra Leone. Have you guys thought about when you're trying to get people to participate, have you thought about using some of the local leaders in medicine that may not be medical doctors in the Western sense? Because a lot of times when you can convince them, and those are the people that people in the village trust or people in the area trust, then you can, if you can work with them, then they can get the people in. Have you guys done any work with that as well?
We haven't done anything yet, but it's on our, like, for the planning of this bigger event we're doing in February in Johannesburg. Absolutely. It's I've been in talks with folks who identify as Sangomas or traditional healers, because exactly what you're saying, like, I agree. And like that's also what, I think is good about having an organization, a public health organization that's run by Black people, is because we think about that, right? Like, people in our community, we get our source of health and spiritual and mental wellness from different places that don't always fit the norm of kind of like the normalized, like, white structures. And so it's important, like, you can't leave those people out, because you then create this like this negativity or between them, right? Like, it's like Western medicine versus traditional medicine, when really we could be coming together, and we could be making sure that, like, in a traditional medicine and things like that are informing our practices, and we are also informing theirs and helping them practice things in a safer way. And even, like, there's probably, like, traditional healers that are doing a good job and those who are not. And so if we can have some regulations and just opinions and just, like, we're all at the table together, we help our community. And so, yeah, like, for me and the work that we're doing and, like, expanding to South Africa, I've always been like, yeah, we can't leave Sangomas out of it. So in the event we're doing in February, I want to have a friend of mine who is a Sangoma. She hosts different types of workshops. She calls it spiritual healing, and she talks a lot about racism, gentrification, and things like that as things that like historical or generational trauma, as things that affect South Africans currently, and their spiritual wellness. And so, yeah, definitely health and wellness, and looking at it from the various facets of Blackness and the way that we work on that. That's really important. So yes.
Thanks for that. I just thought it just made me think about that and the trust that we just don't have, and who we actually trust. And if Western medicine could find the value in looking at the similarities versus not, versus judging, right, people who follow it, I think it would have a different result.
I agree completely.
Yeah. And even the term Sangoma also has some negative connotation here. I'm here with the healer right now, and she was like, I'm a healer and blah, blah. And I was like, what's that called here in South Africa? What's the name? She's like, Sangoma. She's like, I don't like using that term because then there's a certain group of people, it kind of shuts them off from the work. And I was like, man, so you just can't win. So I find it, yeah. And so I'm asking her if she would like to come to this space and share with us too. So people who are listening to this recording, I'm hoping to get her in this space as well, because the work that she's doing, I think, is so interesting and amazing. And I know that there are a lot of folks who are now starting to try to go back to traditional healing and looking at natural medicines and things like that, in a world where we've maybe spun out of control with all of our chemical and pharmaceutical this, that, and the other. So I think there's space for both, and it would be interesting to hear more practitioners speaking on that.
Mhm.